So if you have, like, a hypermobility spectrum disorder, your joints are incredibly loose.
Right. Yeah, that's the
Oh,
hallmark of it.
and you would logically think, okay, my joints are loose, so my muscles must follow suit and be loose too. But today, we are actually looking at this staggering statistic from the clinical literature.
Oh, it completely flips that assumption on its head,
It really does. It says that up to 64% of people with hypermobile Ehlers-Danlos syndrome report severe penetration resistance and pelvic pain.
which is just a massive number.
Yeah, I mean, their muscles aren't loose at all. They're locked shut like a vault. And today, we're basically finding out why.
Yeah, we're diving into a really massive stack of sources today. We've got clinical reviews from the International Urogynecology Journal, plus patient protocols from specialized physiotherapy clinics like Pelvics.
Right.
And we're also pulling insights from experts out in the field, like Dr. Laura Glazebrook and the Fibro Guy.
So, welcome to the deep dive. Our mission today is to answer one highly specific, incredibly important question for you. Can hypermobility spectrum disorders actually cause this reflexive protective pelvic floor bracing that, drives severe penetration resistance?
Because it's such an overlooked issue.
It really is. Like, if you are listening to this right now and you live with EDS or hypermobility, you've probably navigated a diagnostic landscape that is just incredibly murky.
Oh, absolutely.
You bring up excruciating pain during intimacy, and you are just told everything looks normal.
Right, because the medical establishment routinely misinterprets what is actually happening in a hypermobile pelvis.
So where do we even start to unravel this?
Well, to understand why this penetration resistance happens,
Yeah.
we kind of have to bypass the basic faulty collagen conversation. Like, we already know the collagen in hypermobility is structural different.
Right, it's stretchier.
Exactly.
Yeah.
But what we need to dissect is the mechanical consequence of that faulty connective tissue when it comes to passive versus active stability.
Okay, let's unpack that difference. Because the body has all these redundant systems to keep us upright, right?
Yeah, it does. So ligaments provide passive stability. They are these dense, fibrous bands connecting your bones to other bones.
Kind of like the framing of a house.
Basically, yeah.
Hmm.
In a typical body, they act like high-tension cables holding a suspension bridge together. When you stand up, those ligaments just take the load.
You don't even think about it.
Right. You don't have to consciously flex your muscles to keep your femur attached to your hip socket. The passive tension of those ligaments just does it for you.
But with hypermobility, those high-tension cables are basically made of bungee cords.
Yeah, that's exactly it. They stretch way too far.
So they don't provide that definitive passive stopgap at the end of a joint's range of motion.
And the brain recognizes that lack of passive stability as an immediate structural threat. I mean, if the ligaments aren't holding the skeleton together, the nervous system has to recruit the active stability system.
Which is the muscles.
Exactly. Your brain essentially commands your muscles to stop acting like movers and start acting like ligaments.
Wow.
It forces them into this state of sustained, low-grade, 24/7 guarding, literally just to hold your joints in their sockets.
It's like pitching a tent where the guy ropes tying it to the ground are way too stretchy.
Right. I love this analogy.
Yeah, so a slight breeze comes along and the tent is just going to shear and collapse. So to keep the tent up, you have to stand there and physically hold the tent poles up yourself all day, all night.
Yep.
And your muscles are the ones holding those poles. You'd be totally exhausted and you would cramp up entirely.
And that sustained effort creates what the sources call the hypermobility paradox. The underlying ligaments are excessively loose, but the overlying muscles are relentlessly tight.
So the tightness is literally a neurological survival strategy to prevent dislocation.
Exactly. It's not just random tension.
But if the entire skeleton is struggling with this lack of passive stability, from the shoulders down to the ankles, how does the pelvic floor end up catching the brunt of the weight?
That is a great question.
Because usually, when doctors hear stretchy connective tissue, they assume the pelvic floor is hypotonic, like lax or weak.
Right, but the clinical data shows the exact opposite. It is frequently hypertonic, which means it operates with an abnormally high resting tone.
It's just clenched all the time.
Yeah, if we look at the pelvis anatomically, it is the keystone of the architectural arch of your body. It transfers the entire weight of your upper body straight down into your legs.
So it's under a massive amount of stress constantly.
Huge amounts of stress. The sacroiliac joints at the back and the pubic symphysis at the front, they're supposed to be incredibly stable. They're meant to be bound by thick, strong ligaments.
But in EDS, those pelvic joints are inherently unstable. The bony ring of the pelvis literally wants to shear and shift with every single step you take.
And the pelvic floor muscles cross all of those unstable joints because the ligaments are failing to lock the pelvis down, the levator ani and the obturator internus.
Those are the deep muscles of the pelvic floor, right?
Right, the deep ones. They have to clamp down to prevent that shearing force. They're working overtime to hold the literal center of your body together.
So they just get totally exhausted and they lock up.
Yes, they just hit a wall.
Dr. Laura Glazebrook's clinic actually provided an analogy in our sources that perfectly visualizes this pressure. She compares the deep core system to a soda can.
Oh yeah, this is a really helpful way to picture it.
Right, because the deep core relies entirely on pressure management. If you have an empty, open soda can, you can crush it with 2 fingers.
Easily.
But an unopened, pressurized soda can, you can literally stand on it and it holds your body weight.
And the pelvic floor is basically the bottom of that soda can. It absorbs immense downward pressure to maintain the rigidity of your core.
But in hypermobility, the connective tissue that makes up the walls of that core, like the fascia of the abdominal wall, is often way too lax.
Exactly. So to maintain enough intra-abdominal pressure to keep you upright, the bottom of the can has to push back harder. It just absorbs all that extra stress.
And the physical symptoms of that relentless clamping are brutal. I mean, we're talking about severe urinary urgency and frequency.
Yeah, because a hypertonic pelvic floor physically squeezes the bladder, giving you this constant nagging sensation of needing to go.
Which is so disruptive. And gut motility is profoundly affected as well, isn't it?
Oh, completely. The gut wall itself is made of connective tissue. In hypermobility, that tissue is stretchier, meaning peristalsis.
Which is the wave-like muscle contractions that move food through the digestive tract.
Right, exactly. That process slows way down, so stool stays in the colon longer, becomes dehydrated, and that leads to chronic constipation.
And then, straining to pass that stool pushes immense damaging pressure right down onto an already exhausted, spasming pelvic floor.
It creates this devastating anatomical loop.
Which really brings us to the absolute core focus of our deep dive today. If the pelvic floor is locked in this state of reflective bracing to keep the pelvis from falling apart, what happens when you introduce an activity that requires those specific muscles to yield and lengthen?
Right, it creates a massive physical barrier. When a person with hypermobility experiences dyspareunia, which is painful sex or severe penetration resistance, it is driven directly by this protective bracing.
So the muscles are literally saying, nope, we can't open?
Exactly. The pelvic floor muscles are acting like a security door bolted shut from the inside. Any attempt at penetration is met with a wall of spasming muscle.
Because the nervous system basically believes that yielding those muscles will cause the pelvis to structurally fail.
Yes, it's interpreting relaxation as an immediate danger.
Let's look at those statistics again because they reframe everything. An international survey from 2021 found that up to 64% of respondents with hypermobile EDS reported dyspareunia.
64%. That is more than 6 times the rate found in the general population.
That is wild. And probable vulvodynia, which is chronic nerve pain around the vaginal opening, affects roughly half of them. I mean, this is a dominant, defining feature of the condition.
It really is. Yet when a patient takes this severe life-altering pain to a gynecologist, they are routinely told that, structurally, everything looks normal.
Because they can't see the spasm on a standard exam.
Right. The pelvic floor isn't torn. The organs look fine on a scan. So the patient is often just handed a glass of wine prescription like, just relax, it's just anxiety.
But hold on, let me challenge that for a second. If we look at the clinical literature in our sources, we see something called the trifecta.
Yes, the big 3.
Right. People with hypermobile EDS very frequently also have POTS, postural orthostatic tachycardia syndrome.
Which is a form of dysautonomia.
Yeah, and it dumps fight-or-flight hormones like norepinephrine into the bloodstream just from standing up. So if the brain is constantly flooded with panic chemicals, isn't that essentially an anxiety response? Why is the medical establishment wrong to label it as anxiety?
Okay, that is a crucial distinction to make. Labeling it as a psychological anxiety disorder completely ignores the mechanical structural trigger of that autonomic reflex.
Oh, I see.
In POTS, the sympathetic nervous system isn't overreacting to an emotional threat. It is overreacting to gravity.
Wow. Wait, really? Because of the stretchy blood vessels?
Exactly, because the blood vessels are made of stretchy collagen, blood pools in the lower body. The brain panics because it isn't getting enough oxygen, so it dumps adrenaline to force the heart to pump harder and the blood vessels to constrict.
So the nervous system is locked in a high sympathetic state just to maintain blood pressure.
Right. And what do mammals do when their sympathetic nervous system is highly activated?
They brace.
They brace their pelvic floor. Think of a dog tucking its tail between its legs when it's terrified.
Mm.
That is literally a pelvic floor contraction.
That makes so much sense. So the physical state of dysautonomia chemically drives chronic muscular tension.
Yes. Now let's add the third part of the trifecta, which is MCAS, or mast cell activation syndrome.
Okay, mast cells. Those are part of your immune system, right?
Yeah, they live in your connective tissues, including the pelvic tissues, and they release histamine to cause inflammation when they detect an injury or an invader.
But how does that immune response actually connect to penetration resistance?
So mast cells possess these things called mechanosensitive ion channels.
That sounds intense.
It's basically a way of saying they can be triggered to degranulate, to explode and dump histamine purely by mechanical stress.
Just from friction or stretching.
Yep. In a hypermobile body, the connective tissue is constantly microtearing. When the pelvic floor is locked in a hypertonic spasm to hold the SI joint together, that mechanical friction literally pulls those mast cell channels open.
Oh my gosh.
So the tissues become completely flooded with histamine, creating intense localized inflammation.
And that explains the vulvodynia. The histamine lowers the firing threshold of the local pain nerves.
Exactly.
So suddenly, a completely normal touch, or just the anticipation of intimacy, is registered by those sensitized nerves as a massive tissue-damaging threat.
Right, and it initiates central sensitization. The central nervous system becomes hyperreactive to the constant barrage of danger signals from the inflamed, spasming pelvis.
So it is a physiological feedback loop of autonomic arousal, immune overreaction, and protective tissue guarding.
Yes, and dismissing this incredibly complex neuroimmune mechanical cascade as psychological anxiety, it just does immense harm to the patient.
It's incredibly invalidating. But wait, I'm stuck on something here.
Okay, what is it?
If we establish that this is a muscle clenched in a physiological feedback loop, why can't the person just actively override it? Like if my shoulders are tense, I can take a deep breath, focus my mind on my tight shoulders, and consciously unclench them. Why doesn't that work for a hypertonic pelvic floor?
To understand that, we have to look at how the brain actually maps the body. The concept is called proprioception.
Proprioception, yeah.
Proprioception is basically your central nervous system's internal 3D software. It relies on sensors called mechanoreceptors, which are embedded in your ligaments, tendons, and fascia.
Like little GPS beacons.
Exactly. These sensors constantly stream data to the brain, telling it exactly how much tension is on a muscle and where a joint is in space at any given moment.
But in EDS, those sensors are embedded in faulty, overly elastic collagen.
Yes. The hardware is glitchy. The stretchy connective tissue absorbs the mechanical force before it can actually trigger the receptor, meaning the mechanoreceptors misfire.
So they're sending bad data.
They send pure static to the brain. In hypermobility, your brain receives fuzzy, wildly inaccurate data about what your pelvic floor muscles are actually doing.
There is this incredibly vivid anecdote in the sources from a specialized clinic that illustrates this perfectly.
Oh, the biofeedback one.
Yes. They had this hypermobile patient hooked up to an internal biofeedback machine. The EMG probes are reading the electrical activity of her pelvic floor muscles, and the screen is displaying it as a line graph.
Right.
And the baseline resting tone on the screen is showing this jagged mountain range of electrical activity. I mean, it's a massive, intense muscle contraction.
And what did she do?
The patient looks at the screen and literally bursts out laughing because she felt completely 100% relaxed.
And that right there is proprioceptive failure in real time.
Wow.
She wasn't suppressing the pain, and she wasn't ignoring the tension. Her brain literally did not possess an accurate map of her own pelvic floor.
Jeannie DeBon, who is a movement therapist heavily cited in the hypermobility research, calls this false stability.
Which is such a brilliant term for it.
It really is. The body has been bracing so intensely for so many years that the brain recalibrates its definition of zero.
Exactly. The clenched hypertonic spasm just becomes the new accepted baseline. The
Mhm.
patient receives absolutely no sensory warning that their muscles are sitting at maximum capacity.
Until they attempt an activity that forces those muscles to stretch, like sexual penetration.
Right.
You are suddenly asking a muscle that your brain thinks is totally relaxed but is actually contracted at maximum capacity to yield and lengthen.
It physically cannot do it. It hits a wall and triggers excruciating pain.
This completely upends the traditional approach to pelvic floor dysfunction. I mean, when a patient presents with pelvic pain or penetration resistance, the default knee-jerk medical advice is almost always, you need to do Kegels to strengthen your pelvic floor.
Yep. And based on everything we've just uncovered about false stability and hypertonicity, that advice sounds incredibly dangerous.
It really does. If the muscle is already locked in a protective spasm, a Kegel is just another contraction. It's like telling a runner who's currently screaming on the ground with a massive calf cramp to stand up and start doing heavy calf raises.
That is exactly what it's like. Prescribing Kegels to a hypermobile patient with a hypertonic pelvic floor will actively make the dyspareunia worse.
Because you can't strengthen it.
Right. You cannot strengthen a muscle that is already exhausted from 24/7 guarding. It has zero range of motion left.
So adding more concentric contractions to an inflamed spasming muscle will only increase the nerve pain and basically solidify the penetration resistance.
Absolutely.
So if the root cause is a hypertonic, poorly mapped muscle desperately guarding an unstable pelvis, and we absolutely cannot strengthen it, what is the actual evidence-based solution here? How do you treat a muscle your brain can't even feel?
The treatment paradigm has to be entirely inverted. You must prioritize down training.
Down training, like teaching it to relax.
Yes. You have to teach the nervous system that it is safe to let go before you ever attempt to build strength. And because of the proprioceptive static we talked about, you cannot do this alone.
So what's the first step?
The critical first step is finding a specialized pelvic floor physical therapist who explicitly understands connective tissue disorders.
Because a standard PT protocol will just hand you a sheet of Kegel exercises.
Exactly, which we know is a disaster.
What does the specialized down training actually look like in practice then?
It relies heavily on remapping the brain. Specialized PTs use biofeedback, much like the anecdote we discussed earlier, to give the brain a visual or auditory cue.
Oh, so they give the brain a workaround for the broken sensors.
Right. If you can't feel the tension, seeing a line graph spike on a screen helps your brain finally connect the neurological circuit to the muscle. They also utilize highly specific manual release techniques.
But manual release of the pelvic floor won't hold if the rest of the body is still unstable, right? I mean, the sources place a massive emphasis on breath work, which honestly sounds way too simple to be effective, but it's actually deeply mechanical.
Oh, it's pure mechanics. The mechanics of breathing dictate the mechanics of the pelvic floor.
How so?
Your diaphragm, which is the large breathing muscle tucked under your rib cage, and your pelvic floor operate as a closed pressure system. When you inhale deeply and expand your ribs, your diaphragm descends.
Right.
To accommodate that downward shift in intra-abdominal pressure, your pelvic floor naturally has to drop and lengthen.
But people with POTS and hypermobility are stuck in sympathetic overdrive. They don't breathe deeply.
No, they don't. They are shallow apical chest breathers. They literally hold their breath as part of their global bracing strategy.
Ugh. So restoring true three-dimensional diaphragmatic breathing mechanically forces the pelvic floor to move through its full range of motion.
Exactly. Releasing the breath physically releases the pelvic floor. It breaks the cycle of static tension.
That is fascinating. But even with biofeedback and breath work, you still have to manage the whole ecosystem of the body. You can't just release the pelvic floor and send the patient out the door, because the instant they stand up, the loose SI joints will shift and the nervous system will immediately lock the pelvic floor right back up to stabilize them.
Yeah, and this is where pacing and load management become absolutely vital. You have to reduce the aggregate strain on the pelvic floor.
So that means addressing everything else.
Exactly. That requires treating the chronic constipation, because every time you strain on the toilet, you are damaging the pelvic floor's coordination.
And managing the POTS.
Right, it requires utilizing electrolytes and medication to manage the POTS symptoms, bringing the autonomic nervous system out of chronic fight or flight.
So you basically have to build dynamic stability in the hips, the glutes, and the core in a really highly controlled way. So those larger muscles take over the job of stabilizing the pelvis,
Yes.
and that allows the pelvic floor to finally stand down.
Exactly. It requires treating the hypermobile body as an interconnected tensegrity structure, rather than isolating a single muscle in the pelvis and ignoring the rest.
We have covered an immense amount of physiology today. I really want to speak directly to you listening right now. If you have spent years being told you are just a bit bendy while simultaneously suffering from unexplainable chronic pelvic pain, or if intimacy feels like hitting a brick wall of excruciating pain, take a breath.
Yeah, let this sink in.
You are not broken, you are not dramatic, and it is certainly not just anxiety.
Your body is actually executing a highly logical, deeply intelligent structural response. It is desperately trying to stabilize joints that your faulty connective tissue cannot hold together.
The mechanics driving your pain are documented, they're proven, and there are specialized professionals who know exactly how to help you remap that nervous system and release that tension.
You just have to look beyond the generic do your Kegels advice.
Right.
And, if we pan out and look at the broader implications of this, it kind of forces a paradigm shift in how we view orthopedics in general.
What do you mean?
Well, if hypermobility proves to us that chronically tight muscles in the pelvis are very often just a protective symptom of loose connective tissue underneath, how many other chronic muscle tension issues across the entire human body are being totally mistreated?
Wow, which really makes you wonder if we've been treating pelvic floor dysfunction completely backward for decades by ignoring the underlying scaffolding. What else are we misdiagnosing?
Right.
That relentless tension headache, that locked up shoulder, those chronic hamstring spasms. Maybe it's not a tight muscle at all. Maybe it's a loose foundation and your nervous system is just trying to hold you together. Something to think about the next time you or your doctor reach for a foam roller to crush a tight muscle. Take this knowledge, advocate for yourself, share it with your physical therapist, and don't stop exploring. Until next time, keep diving deep.